Good afternoon, everyone. A warm welcome to all our participants to this session of ultrasound webinar. And thank you for joining us from various locations in Asia, including Philippines, Vietnam, Cambodia, Thailand, Indonesia, Japan, and here in Singapore. The theme of today's webinar is Changing Paradigms in First Trimester Ultrasound Screening. I'm Dr. June Tan from the Maternal Fetal Medicine Department and Antenatal Diagnostic Center at the KK Women's and Children's Hospital in Singapore, and I will be the chairperson for today's webinar. We are indeed very fortunate this evening to have with us two eminent speakers, Professor John Hyatt, Professor of Obstetrics and Gynecology from the University of Western Sydney in Australia, and Dr. Chang Tao Chung, Clinical Director of the Fetal Assessment Unit at the Singapore Women's Medical Group in Singapore. The webinar is jointly organized by OGSS and the Canon Medical Systems in Asia. I'd like to run through the agenda for the meeting. So we have three very interesting lectures. The first one is First Trimester Screening for Preeclampsia, the case for universal screening by Professor John Hyatt. This will be followed by Dr. T.C. Chang's lecture on first trimester combined screening versus first trimester anatomy scan plus NIPT, cut-offs to use and what confirmatory tests to offer, PCR, CMA, resorpathy panel, and a whole exome sequencing. And this will be followed by another lecture by Professor John Hyatt, who will talk on screening for premature labor, when should we screen, and what screening modalities to use. At the end of the session, we will reserve all the questions for the Q&A session. Questions can be submitted via live Q&A at any time, and we will try our best to address all questions. So we will now start with the first lecture, and it is my privilege to introduce to you Professor John Hyatt. So Professor Hyatt's current position is that of Professor of Obstetrics and Gynecology at the University of Western Sydney and practices obstetrics and maternal fetal medicine at Liverpool Hospital, South Western Sydney Local Health District. Professor Hyatt was formerly head of high-risk obstetrics at the Royal Prince Alfred Hospital in Sydney, specializing in antenatal and intrapartum care, ultrasound, and fetal medicine. He is internationally renowned for his research record in fetal medicine, including the publication of over 90 original research papers, topic reviews, and book chapters. His thesis is on the subject of screening of congenital cardiac defects with a nucleotranslucency assessment. He is an expert in the development of predictive models that describe the risk of adverse pregnancy outcomes and the provision of preventative intervention. Other research interests include the management of twin pregnancies and the development of intrapartum interventions that reduce the cesarean section rates. Professor Hyatt is also the Distinguished Trustee of the Fetal Medicine Foundation in the United Kingdom, as well as Trustee of the ISWOC Society, International Society of Ultrasound in OAG, and is the immediate past chairperson of the Education Committee in ISWOC. So without further ado, Professor Hyatt will now deliver his presentation on the topic of first trimester screening for preeclampsia, the case for universal screening. So Professor Hyatt, please.
So thank you for inviting me to talk today This is the first of 2 talks I'm going to give. This is on first trimester screening for preeclampsia, and I'm going to focus on the case for universal screening. So let me step back more than 100 years to this guy, John Ballantyne, who was the medical superintendent in Edinburgh. And he had some novel ideas about care for pregnant women. And one of them was a concept of having antenatal inpatients. And another of them was just the general concept of antenatal care. And he said, and this is in 1902, the medical profession stand upon the threshold of antenatal therapeutics. It has been standing so long that you begin to wonder whether it intends to enter in or means to turn away. A statement made over 100 years ago that I can really appreciate. So this slide just illustrates the difficulty of implementing some research findings into clinical practice. The hills and valleys on the left-hand side basically show you the process of taking something from basic science through clinical implementation with a process of clinical study in the middle, which tells you how well this test is performing. And you can see that not everything that we identify through basic science makes it to the end game of implementation. In fact, some people reckon that only 5% of investigations that start with basic science end up being used clinically. The other side of that is that implementation process takes about 15 years. So what are the roadblocks to implementing preeclampsia screening in practice? Well, people commonly say it's because there isn't enough data. I think I'll refute that. They say it's because preterm preeclampsia is uncommon. That's true, but it's a very significant disease. They say the screening test is too complicated or too expensive. And they also talk about just giving everybody aspirin. We'll deal with those issues as we go along. So first of all, what's the rationale for screening? Well, the simple rationale is that preeclampsia, whilst it's relatively uncommon, affects the lives of women and children really quite fundamentally. From a worldwide perspective, about 60 to 70,000 women per year die of preeclampsia. From a neonatal perspective, about 500,000 babies are born too early because their mother has preeclampsia and die. And that's just talking about mortality. That's not talking about the morbidity associated with this condition, either for mothers or babies. Mothers that have preeclampsia are about 3 to 4-fold more likely to get cardiovascular disease in their later life. And the babies born prematurely to women who have preeclampsia tend to have ongoing problems with metabolic syndrome, diabetes, cardiovascular disease, again, for the remainder of their life, together with the other neurodevelopmental risks of prematurity. The good news is, I think we know a lot more about the etiology of preeclampsia now than we did even 15 years ago. And we've really, I think, now recognized that this is a disease that has stages of progression. And some of those are, if you like, preclinical before you see the clinical signs of this condition. So if we just work backwards, down in the bottom right-hand corner, we make a diagnosis of preeclampsia based on clinical signs, hypertension, proteinuria, and or other organ failure. This process of prediction and prevention is not about that. It's about recognizing a much earlier stage of disease before you have clinical symptoms. So we're talking about the recognition of placental dysfunction that in turn leads to vascular compromise, and that is what then produces the symptomatic effect. So what we're aiming to do is correct the placental dysfunction and prevent the vascular compromise. And the best time to do this is early in pregnancy. So Leona Poon, when she was working with Kypros Nicolaides in London, demonstrated that we can predict placental dysfunction at 12 weeks of pregnancy. And you can see that this test uses uterine artery Doppler, mean arterial pressure, and then two biomarkers, PLGF and PAP-A. And with that combination, she could predict 90% of women that would need delivery for preeclampsia before 34 weeks, with about a 5 to 10% screen positive rate. So the question is, can you reproduce that in other settings? Well, this is the data first that shows you the biochemical changes. So you can see PAP-A on the left, PLGF on the right, both listed as MOMs on the y-axis, and then comparing different populations. And you can see a similar turn of events with both hormones. So basically, levels are reduced in preeclampsia, and they're reduced to a greater degree the earlier that you have that disease process. We've tried to reproduce some of the data for preeclampsia screening in an Australian population, because obviously the FMF algorithm is derived in a London population, part Caucasian, part African or Caribbean women. And that's actually quite different to the population that we have here in Sydney. So the first thing we wanted to do was validate the algorithm in our local population. Felicity Park, one of my colleagues, did that in a study of about 3,000 women and basically demonstrated that we had exactly the same first prevalence of early onset preeclampsia, but second, the same predictive value of this test in our population, and were able to predict about 90% with a 10% false positive rate. And interestingly, if you look at the receiver operator curves, you can see that actually that's a pretty straight line going up to that 90% detection rate. So there's not much value in setting the false positive rate at 5%, you'll end up with half the detection, or at 15%, you don't really actually improve detection much beyond that. So we set this limit of using a screening tool that will identify 10% of women as being high risk, and that identifies 90% of the cases of early onset preeclampsia. This slide also shows that this test doesn't work very well for late onset preeclampsia. Now, there's now a whole range of data sets that have demonstrated the value of this algorithm in different populations. So on this slide, there's a data set from Vietnam, there's a couple of data sets related to the US and to Brazil. So really, we've now got good data in a whole range of different ethnic groups, demonstrating that this algorithm really seems very robust internationally. So the next step is linking prediction to prevention. And again, we've done a cohort study here in Australia where we were able to demonstrate this. This cohort study, we again showed about an 80 to 90% reduction in the prevalence of early onset preeclampsia when we gave aspirin, 150 milligrams Nocte, from 12 weeks of pregnancy through to 36 weeks of pregnancy to these women. Another implementation study of this was recently published by Baski Thilaganathan's group at St George Hospital. Guy is the first author, and you can basically also see very similar data. Probably the easiest way to look at this is the graph on the left-hand side. You can basically see that the early preeclamptic cases, are particularly between 25 and 28 weeks gestation, are just really removed from the graph. And both of these implementation studies really support the findings of the really large ASPRE study. Again, this is a multi-center European study that demonstrated about a 62% reduction in rates of preterm preeclampsia. And if you went back to look at the data before 34 weeks, you can see it's an 82% reduction. This was a study that enrolled 30,000 women. It's a randomized controlled trial. It's really the best quality of evidence that you can get. So what about the argument that we should just not bother with screening and we should give everybody aspirin? Well, there are actually a number of trials which have looked at whether you can give aspirin to a population of women. Often it's been given to all nulliparous women. And then they've looked to see whether that's had an effect on rates of preeclampsia. So probably the three best and most complete trials, actually quite old, late 1990s and early 2000s, done in Jamaica, Barbados and France. And the biggest issue was actually compliance. So if you don't have a good reason to take aspirin and you're a pregnant woman, you don't really want to. And you can see that compliance rates were only about 50%. And in those randomized controlled trials, there was no impact of the treatment on the outcome. So personally, I don't think there's any data to support the concept of giving all women aspirin. Back to implementation. The cheapest part of implementation is measurement of blood pressure. But it's important that it's done in a standardized way, using equipment that's validated for use in pregnancy. And that way you can take the raw measurements, which you can see here on the left-hand side. You can see what happens with mean arterial pressure. It goes down in the second trimester, then comes back in the third. And you can convert those on the basis of different maternal characteristics. You can see on the right, racial origin, chronic hypertension, diabetes, conception, smoker. So you can basically take your raw data and then convert it into what's known as a MOM value. And when you use those characteristics to produce MOMs, you can see that the preeclamptic group, which are on the right-hand side in red, have higher MOM values for blood pressure. Now, it's really important that we measure blood pressure accurately, and therefore it's really important that as part of that process, we actually look and reflect on our data and make sure that our normal data compare to those of other groups. And this is an example of the audit tool that is available online on the Fetal Medicine Foundation website that you can use to check whether your blood pressure measurements are correct. So the next tool that I would use from a screening perspective is uterine artery Doppler, because this is an easy add-on to the first trimester scan for aneuploidy. Interestingly, this data shows you that uterine artery Doppler can be used to distinguish between the low Pape measurements that you see in a down population, where the uterine artery Doppler is essentially normal, and the low Pape measures you get in an early preeclamptic population, where the uterine artery Dopplers are raised. So there is actually more than one value to making this measurement in your aneuploidy screening. So this is just an example of the waveform that you get when you look at the uterine artery Doppler. In the first trimester, we use a technique where you essentially come in a mid-sagittal section, you pick up the cervix transabdominally, and then you move the probe either to left or right of the cervix to pick up the uterine artery, which you can see here in colour. It's important that you pick it up at the level of the internal cervical os. We then have three nice waveforms that we measure our PI over. People often ask me what the normal range for PI is. This is an example. So you can see normative is about a threshold of about 1.7 going down to 1.5 over that 45 to 84 millimeter CRL range that we know is the 11 to 13 plus 6 week scan. But actually the raw value, again, is not important. What's important is that you convert this to a MOM value. And again, this is just to demonstrate the fact that what we then know is that normotensive women tend to have lower MOM values for their uterine arteries than the preeclamptic data set. So what you're going to be able to do is develop likelihood ratios just in the same way as we've been doing for nuchal translucency and for biochemistry for aneuploidy. And this just shows you the impact of adding uterine artery Doppler to history. It basically improves your ability to predict early onset preeclampsia by about 30% upon the basis of history alone. So just some more examples. So this is actually looking at the uterine artery Doppler in a transverse section. So you can actually come down to the level of the cervix as you work your way down from the uterus, and then you can put the colour on. You can see both uterine artery Dopplers here. There are data to demonstrate that this is just as an effective way of making this measurement. So if you find the mid-sagittal approach difficult, you can use this. And then this is also just to demonstrate that you can use a transvaginal approach. So if you say are measuring cervical length in the first trimester, if you just rotate the probe about 40 degrees and then come out to the lateral wall of the cervix, again you can just see that you can pick up the uterine artery quite clearly using a transvaginal approach. So when we talk about uterine artery Dopplers, again, we are doing this process of momming the data, and the table on the left just demonstrates the fact that we do this by calculating maternal BMI, looking at the gestational age of the pregnancy, and then we also take account of parity and ethnicity of our patients. And finally, from a QA perspective, we're able to plot each scan that a sonographer does to define whether we're lying within a normative range. So this is a process called a custom plot. It basically follows each individual scan you do, and the red dotted lines here basically define the point where you would say that that sonographer is either over measuring consistently or under measuring consistently. And this is another audit tool that we have, again available to us on the Fetal Medicine Foundation website. So we talked earlier about biochemistry, and we talked about using PAP-A and PLGF. I think there is an advantage to PLGF compared to PAP-A if it's available to you. Now, obviously, there's a potential cost to that. So the question is, could you perhaps use PLGF instead of PAP-A for aneuploidy screening, and then you get the best of both worlds? So we do know that PLGF is an effective tool in screening for trisomy 21. This is an early piece of work that demonstrated that. You can see bottom right-hand corner that if you added PLGF to the typical first trimester test for aneuploidy, it allowed you to reduce the false positive rate and slightly improve the detection rate. There is actually another piece of work now that demonstrates that you can replace PAP-A with PLGF and just use a dual biochemical test in the first trimester with very similar levels of sensitivity to what you would have if you used PAP-A and beta-HCG together. So finally, how do you persuade the administration that investing in a screening program for preeclampsia is worthwhile? Well, I think it's important to recognise that preeclampsia is actually costing us a vast amount of money. This is data from California. It was published in 2013. It's a statewide project looking at the costs of preeclampsia. And they basically demonstrated that preeclampsia was costing California about $210 million a year. About $176 million, so it was about 3/4 of it, was actually managing preeclampsia for babies born before 34 weeks of gestation. Now, what was interesting about the ASPRE study was that they measured rates of NICU admission, and they didn't actually show a significant reduction in rates of neonatal admission. But they then went on to actually look at those individual cases of neonatal admission, and the middle chart of this slide shows that whilst they had a very similar rate of admission, they actually had 68% less neonatal days of admission, because these babies weren't being born as early, and therefore they weren't staying in the neonatal unit as long. And that becomes the crux of a financial argument for why you should screen for preeclampsia. Because you can see in this data set, which is from Sydney and from Newcastle, two centres in Australia, and this is basically a health economic analysis that looks at the cost of instituting screening for preeclampsia compared to usual care. And all those little orange dots down in the bottom right-hand corner of that graph are looking at something called a sensitivity analysis, so that's varying various factors in the algorithm for how effective screening would be. But basically they show you that the screening test and then use of aspirin to prevent preeclampsia is basically costing us less money and reducing the number of cases of preeclampsia. And that's universal. It really doesn't matter where you are with that sensitivity analysis. This is completely dominant over usual care. And finally, if we put that in the context of an individual unit, this is some work we did, again, with Felicity Park in Newcastle. And you can basically see that we've predicted that through a program of first trimester screening, we would save the hospital about $2.3 million per year. And we've also demonstrated that we would reduce the number of neonatal bed days by about 950 days per year. Now, in my mind, that's the more significant issue, because we are always full of our cots, and that basically means we've got 3 extra cots available every day of the year for other indications. So I just wanted to end by reminding you that predicting outcomes is very difficult, especially about the future, and that was a quote from Niels Bohr, who was a Danish physicist and Nobel Prize winner for his atomic physics in the 1920s. Thank you.
Thank you, Professor Hyatt, for the excellent lecture. I'm sure our participants have many questions, and we will be discussing them at the end at the Q&A session. So our next speaker is well known in the field of fetal medicine in Singapore, and I'm pleased to introduce my friend and colleague, Dr. Chang Tao Chung. So Dr. Chang is consultant obstetrician and gynecologist at the W.C. Cheng and Associates Thomson Medical Center. He's also a consultant in fetal maternal medicine at Thomson Medical Center and clinical director of the Fetal Assessment Center at the Singapore Women's Medical Group. Dr. Chang started his undergraduate medical training at Guy's Hospital Medical School at the University of London. He graduated in 1985 and worked at many London teaching hospitals, including Guy's Hospital, Hammersmith, Charing Cross, and University College Hospital. In 1990, he obtained his MRCOG and FRCS qualifications. Between 1991 and 1993, he completed his obstetric ultrasound research, which led to his submission of a doctorate MD thesis entitled Serial Ultrasound Assessment of the Growth Restricted Fetus, and was awarded MD by the University of London. Dr. Chang has been working in Singapore since 1994 at the KK Women's and Children's Hospital, and thereafter from 1998 at Thomson Medical Center. He was appointed consultant in the Department of Maternal Fetal Medicine in KK Hospital in 1997 and was a visiting consultant from 1997 to 2006. From 1998 to 2002, he was the head of the Fetal Assessment Unit at the Center for Prenatal Diagnosis and Obstetric Ultrasound at Thomson Medical Center. In 2005, Dr. Chang was Associate Professor in Obstetrics and Gynecology at the University of Auckland in New Zealand. And between 2007 and 2009, Dr. Chang was also the President of the College of ONG in Singapore. So Dr. Chang's clinical interests include first trimester screening for chromosome aneuploidies and other pregnancy complications like preeclampsia, fetal growth restriction, premature labor, management of high-risk pregnancies, ultrasound assessment of at-risk fetus, and invasive prenatal procedures. So without further ado, please welcome Dr. Chang. His lecture will be on first trimester combined screening versus first trimester anatomy scan plus NIPT, cut-offs to use and what confirmatory tests to offer, PCR, CMA, resorpathy panel, and or whole exome sequencing. So Dr. Chang, please.
Good evening, fellow colleagues. Welcome to the second talk in our series today on the changing paradigms of first trimester screening. And I'll be addressing the issues of screening in the first trimester for chromosome abnormalities. I'll be addressing some of the controversial topics and also to maybe to increase our sort of level of inquiry of the chromosome problems that can be in the fetuses that we see in the first trimester. I'm grateful to Canon for sponsoring this talk, as well as to the ONG Society of Singapore for hosting this talk as well. For today, I thought we would be good just to do a bit of revision of the principles of first trimester screening. Maybe have a bit of a debate about whether we should still be using combined first trimester screening or whether we should be veering more towards the first trimester anatomy scan and an NIPT. What cutoffs that should we use for NT measurements? Also think a little bit more about the invasive tests that we offer. Of course, we have spent the last 2-3 years educating our colleagues on the importance of offering chromosome microarray as a pretty much a standard test now during our amniocentesis and chrononuclear samplings. Also addressing the question of whether we should be adding Noonan's panel or the Rhizopathy panel, as well as revising some of the criteria to use should we be considering whole exome sequencing as well. So it's quite a lot of topics to get through in the next 25 minutes, but I think it'd be good just to make an attempt at that. I think, and this is a very, very important paper which I will be referencing twice in my talk. This paper really sort of crystallizes our thinking really on what are we actually trying to achieve in our first trimester screening and some of the changing paradigms as a result of that. This is a paper from Professor Katia Bilardo's group, first author Francesca Bardi and colleagues from Holland. And I think the next slide really sort of highlights the general concept of what we're trying to achieve in our first trimester screening in our patients. Of course, we've been, for the last 20, 30 years, been fixated on screening for the 3 trisomies, 21, 18, and 13, quite rightly so. But I think you as my colleagues would agree that really we've shifted the paradigm, and the objective of screening really should be enhanced. And we're not really only screening for trisomies 21, 18, and 13, but other chromosome abnormalities, as well as submicroscopic deletions or chromosome microdeletions, as well as single gene disorders. And this paper would really highlights the importance of the first trimester scan, in particular the nuchal translucency measurement, in determining whether the patients are high risk for any of these trisomies, microscopic deletions, as well as single gene disorders. And I would ask you to put it in your, just to remember these 2 categories, the chromosome microdeletions as well as the single gene disorders, which I shall try and address a little bit more in the second half of my talk today. So look, we need to know and acknowledge where we've come from. Conventional first trimester screening is a no-brainer. This has been offered for the last 20 years, basically. And we're used to do combined first trimester screening, combination of age, nuchal ultrasound, nasal bone, plus or minus ductus venosus, and plus the 2 biochemical hormones, PAPA and free beta. We then use a predetermined cutoff of 1 in 300, and we decide whether they're low risk or high risk. Using this, we would have a 5% test positive rate, and then we offer them either a choice of an invasive test or an NIPT. And if they're screen negative, i.e. they're low risk, then they move on and have an anatomy scan at 20 weeks. But I would put it to you that the clinical scenarios which we face every day don't quite fit into that category. And these are 3 of the scenarios which I thought I'll bring up. As clinicians, we think we're offering first trimester screening to patients to screen for 21, 18, and 13. However, you would acknowledge that a lot of your patients and my patients would have previously walked away from that consultation thinking they've been offered first trimester screening for chromosome abnormalities in general. And hence, this really raises the importance of pre-test counseling, post-test counseling, and really the acknowledging the problem that there has been a lot of mismatched expectations between what we offer and what the patient thinks they're being offered. Second scenario happens all the time. Patient walks into your clinic at 11 to 12 weeks of pregnancy, and they wave the NIPT test result in front of you and say, hey, look, I've had it done elsewhere at 9 to 10 weeks, and what should I be doing next? So as a clinician, the question you have to offer them is, or to ask yourself is, should you be offering them a first trimester anatomy scan? And the very short answer to that is yes. The third scenario, maybe you're in an institution and you're really following your institutional practice or guidelines, and you offer combined first trimester screening to all your patients. Well, the patient says, yeah, I hear you, but I want an NIPT. So what do you do as a clinician? Well, the next slide really would address some of the questions that may be asked. Of course, now we also have contingent stepwise screening, whereby you can actually do an OSCAR or combined first trimester screening, but you triage them into low risk, intermediate risk, or high risk, and you can decide to offer your high risk patients, i.e. a cutoff of more than 1 in 50, a CVS or an amniocentesis. You can offer an NIPT to your intermediate risk category of between 1 in 50 to 1 in 1,000, or you can decide if they're low risk on the OSCAR, that you would then triage them into the low risk category, and they can just thereafter have an FA scan at 20 weeks. There are, of course, discussions whether we should be using 1 in 50 or 1 in 100. There are also certain caveats, as you notice down here. I've put down 5 caveats that you may wish to consider if you have got a very low free beta MOM or a very low PAPE MOM, being less than 0.2. You may wish to offer them an invasive test outright. If the age is more than 42, if the nuchal is more than 3.5, if you find a fetal structural abnormality, you should consider offering them a CVS or an amniocentesis for an outright culture plus CMA, or some folks would offer a PCR and a CMA. That's fine. Okay, so these are some of the caveats you need to build into your stepwise contingent screening. Or lastly, to answer the scenario that I posed you, the last scenario, we may wish to, and I think most of us would be veering more towards this anyway, and this is actually what's happening in most practices these days. You get a patient in the first trimester. If they've done the NIPT, you still do the first trimester scan. If they haven't, you do your first trimester scan. You make sure that they haven't got any abnormalities, make sure the nuchal is normal, and then you offer them the NIPT. However, if you find that on your scan in the first trimester, you detect a fetal structural abnormality, or the nuchal is more than 3.5, then that patient really shouldn't be offered an NIPT, and you then should offer them an invasive test for a chromosome microarray and a PCR to screen for chromosome microdeletions. So this is something that most of our colleagues will be practicing anyway, and this is that there's a lot more to this than this slide, which I'll try and go into subsequently. I think it'd be interesting to look at some of the other issues. Look, we are all familiar with the measurement of the nuchal translucency. We know that the nuchal translucency is actually very accurately reproduced if you follow the guidelines. This is here a fetus with a nuchal of about 1.6 millimeters. And here we have a nuchal of about 2.0 millimeters. Of course, we need to know what the gestational age is, because you can then actually plot it on the graph with the gestational age or the length of the fetus on the x-axis, and the measurements of the nuchal on the y-axis. So this is familiar to all of us, and you know that the nuchal increases in thickness with advancing gestational age. I think we know enough in the last 5 years, really, with the introduction of the NIPT, as to the detection rates for the 3 trisomies. We're familiar with the positive predictive values, and we've had lots of lectures on the benefits of the NIPT if you get a result. I think that the caveat has to be added that if you get a result, which is usually 97% of the time, you can depend on the sensitivities as printed here, basically 98 to 99% for all the 3 trisomies. Of course, then begs the question, what about the 3% of your patients who may get a no-call result? That means you have a none result from the NIPT. What do you do next? We've covered this in many, many other lectures. You've got to put them through your first trimester screening again and highlight the increased risk of chromosome abnormalities within that cohort. I think the other benefit of the NIPT really is that you get an opportunity to screen for 22q11, and really this is not addressed at all in the conventional combined first trimester screening. I'm grateful to Dr. Dar for these slides, which were first presented in the MFM meeting almost a year ago. And this is really the data from the SMART study, which has also been published since, looking at an incredible wide population study of about more than 20,000, involving more than 20 global centers, and with the benefit in this particular study of having not just done primary screening on all the patients, but also getting a genetic follow-up by chromosome microarray as a postnatal confirmation. So these are all patients who have been enrolled, singletons, more than 9 weeks, who had cell-free DNA testing done by the Panorama SNP technology. The first two columns here, the sensitivity and specificity, I think we do know that the NIPT, particularly the SNP-based NIPT, does detect up to 83% of the 22q11 microdeletions. But I think the new data that's presented from the SMART study shows that the positive predictive value, previously 23%, has now been increased to 52% using the AI technology, which is now incorporated into the SNP-based tests that we are being offered these days. So it is quite an impressive increase, more than doubling of the positive predictive value using the SNP technology. So I think we do certainly want to highlight the benefits of using an NIPT that will now give us a lot more information when we screen for the 22q11 microdeletion. And of course, that we can deliver another whole lecture based on the comparative results of the various different types of NIPT. But suffice to say that now we're getting detection rates of about 83% and positive predictive values of about 53%. I think one of the issues which I'm trying to address in this lecture today is really, what should we do if patients just come to us with an NIPT result? The results have been made available to the patient. They're still in the first trimester. They haven't had a first trimester scan. What should we do? I think the short answer is do the first trimester scan, do the nuchal measurement, and look at all the fetal organs in the anatomy survey as you should have done. And I think this is one of the important papers. This was a paper from the Spanish group, Miranda and colleagues, published in 2020, and highlights the problems if you had just depended on an NIPT in the first trimester to screen for fetal trisomies or fetal chromosome abnormalities in general. Very interestingly, in this group of high-risk fetuses, they looked at 226 fetuses with a thickened nuchal, and in that paper, the definition was a nuchal of more than 99th centile, and they found that if you had screened for using the NIPT only, you would have missed quite a substantial number of chromosome abnormalities. Granted, they would have detected 68 aneuploidies, but using conventional screening, using NIPT, which only screens for 21, 18, and 13, you would have missed these chromosome abnormalities. The next slide will elaborate further on that. 16 out of the 84 genetic abnormalities would have been missed if you had just screened using NIPT and not done a first trimester screening scan. If you had done a first trimester screening scan, you would have used the cutoff of a nuchal thickness of more than the 99th centile, and you would have at least picked up the additional 16 of the 84 genetic abnormalities. This is a flow chart of how the patients were, the results were revealed. And I think I would like to just highlight this here. There are actually within the 16 quite a lot of abnormalities, some of which may have been picked up on an NIPT. If you had used an NIPT which actually screens for monosomy X and the sex chromosome aneuploidies, you might have picked this up, but the others would not have been picked up. And I'd like to highlight what would not have been picked up. So these here may have been picked up if your NIPT incorporated screening for sex chromosome aneuploidies. It wouldn't have picked up 47 trisomy 22, and you would not have picked up these abnormalities, which are abnormal copy number variants, because these were all microdeletions and would have been completely missed. It would also have not picked up two fetuses with Noonan syndrome as well. So I think the answer to the question, should you do a first trimester scan after an NIPT result has been made available, is a categorical yes. What should you do next if your nuchal is thickened? Well, put it the other way around. If you haven't done NIPT, I think the right thing to do is to offer that patient an invasive test, and that would be either a CVS or an amniocentesis, because that would actually give you a lot of information on the chromosome microdeletions. You should also arrange for a fetal cardiac scan or early anatomy scan at 15 to 16 weeks, because actually that scan would detect quite a lot of fetuses with structural abnormalities as well. And in a paper by Lelou and colleagues in the Prenatal Diagnosis 2016, if they broke down the abnormalities that were detected either at the first trimester scan, the early second trimester scan, or the 20-week scan, you'll see that the first trimester scan would detect about 31%, the 16-week scan would detect 41%, and the 20-week scan will detect the remaining 27%. So actually you get most of the abnormalities picked up at the 16-week scan. You also have to ask yourself the question, whether offering the CMA is enough, or whether you should be considering more than that. Should you be considering offering a Noonan's panel or a rhizopathy panel or whole exome sequencing? You should also ask your question, have I actually referred this patient to the fetal medicine consultant and had a consult with them? And should I be referring this patient for a genetics consult as well? I think I don't think I need to convince our colleagues that the first trimester scan cannot be just an NT scan, because essentially we're looking at all the fetal organs in the first trimester of pregnancy as well. And just to eliminate any doubt, we're actually getting detection rates in the first trimester of pregnancy now for major cardiac abnormalities of about 60% or more. And this is a paper recently published by Karim and colleagues in the White Journal in 2022. And I would therefore ask all our colleagues to think of the first trimester scan as an anatomy scan, certainly not as an NT scan. Of course, then that raises questions, well, what NT cutoff should we be using? Should we be using a cutoff of 3.5 or should we be using a cutoff of 3? Okay, in this particular fetus with the NT of 3.6, it's a no-brainer. You should be offering a chromosome microarray plus, yeah? And of course, the question then, what about this fetus? Okay, this is a patient with a fetus, a nuchal thickness of 3.2. Does it warrant an invasive test, and does it warrant a chromosome microarray? Well, I think one of the best papers to have addressed this is a paper by Lisa Hui and colleagues from Melbourne. It's one of many papers that have attempted to look at this question, and you can see that there are many papers. There are at least 6, if not more, that have been trying to see whether a nuchal of more than 3, a nuchal of more than 3.5, or in some papers, a nuchal of more than 99 centile should be used as the cutoff upon which to offer CMA. And I think sometimes we could be arguing, 3.5 versus 3, but Lisa Hui and colleagues have presented some very good data to suggest that we should maybe be looking more at the 99 centile, as shown here on this graph in bold black, unbroken line, which is the 99 centile. And as you can see, it of course increases with advancing gestation, and it may be something that we have to think about instead of using an arbitrary cutoff of 3.5 or 3. But be that as it may, we have come from a nuchal cutoff of 3.5, and there is some data to show that we may be worth considering sticking with 3.5 until we have more data to show otherwise. I would show some of the data here from Professor Hui's paper, whereby they looked at, should we be using a nuchal thickness of 3.5 or 3? And how many more atypical chromosome abnormalities will we pick up? Well, I think this paper shows quite elegantly that if you use a cutoff of 3.5, you would have picked up about 20 chromosome microdeletions and microduplications. If you had used a different cutoff, a bit more of a cutoff of 3.0 or more, you would have picked up an extra 2 atypical chromosome abnormalities. But look at the numbers here. You would have included a lot more fetuses for which you would have had to offer an invasive testing, pretty much a doubling in your invasive testing rate from about 491 to about 1,025, just to pick up those 2 extra atypical chromosome abnormalities. So I would certainly consider sticking with a 3.5 millimeter cutoff for the time being, although there are many papers that which show that you might want to consider 3.0. What is the incremental yield of a chromosome microdeletion with a thickened nuchal? And again, here I would suggest that you use the cutoff of either 3.5 or a cutoff of more than the 99th centile. You're going to get an incremental yield of about approximately 4%. If you use a cutoff of 3 millimeters to 3.4 millimeters, you're getting an extra 1%. And therefore, I'm sticking to 3.5 millimeter cutoff, and I can with confidence know that the incremental yield in an isolated nuchal thickness of 3.5 will be about 4%. Now, this is a very important paper for counseling, and I would like to, if there's any paper that you remember from this particular talk, I would ask you to remember this one. And this really tells you counseling-wise, what the chance of a life born with an abnormality is, or what the chance of a life born without the abnormality is. So let's look at the cutoffs, and it's very helpfully triaged into 3.5 to 4.4, 4.5 to 5.4, and so on. And you can see that if you use a cutoff of 3.5 or more, there is a 1 in 10 chance that there is a risk of an abnormal account. And that risk increases dramatically when you go beyond 5.5. There's a 5 in 10 chance of an abnormal outcome. And therefore, these are very helpful for counseling, especially when you go into the 5.5 or more than the 6.5 mm category. Because what the patient wants to know is, what does that mean in practice, doctor? Does that mean I'm going to have a baby that is unhealthy? And you can, from data, give them a sort of answer, a sort of odds really, and that if you have a 5.5 mm cutoff or more, there's a 50% chance of an abnormal outcome, and therefore a poor prognosis. So I find this particular chart from Aris's paper in the European Journal particularly helpful when counseling patients with an abnormal thickened nuchal. I think it's important in a talk like this really to make ourselves think, you know, is doing a chromosome microarray enough? Should we be offering a Noonan's panel or a rhizopathy panel? Sometimes when I take some of the trainings for exam training and all that, I find that they use the two terms interchangeably, and it's actually not the same. Noonan's syndrome refers to a certain group of rhizopathies, and they're not by no means all the rhizopathies. Rhizopathies, as you know, are abnormalities in the RAS MAPK signaling pathway, which usually ends up in fetuses with very thickened nuchals and, of course, accumulation of fluid in most of the body systems. Noonan's does account for quite a lot of the rhizopathies. In this particular paper by Badi, if you break down all the rhizopathies, it was 18 of the 20 rhizopathies were actually Noonan's syndrome. But don't forget that rhizopathies do not make up all the single gene disorders either. They probably make up about just over 50% in this particular paper, again, from Badi's group in the prenatal diagnosis 2020. You see that of the 38 single gene disorders, the rhizopathies were made up about 20. So it's about just over 50% of all single gene disorders were rhizopathies. But of course, remember these are other single gene abnormalities, not rhizopathies, that can also occur when the nuchal is particularly thickened. Therefore, question, of course, is asked, what's the yield of rhizopathy testing after you've done your CMA, you've done your PCR, you've got a normal result, and you started up with the fetus with an increased nuchal thickness? Well, the yield is actually quite low if it's an isolated thickened nuchal thickness. If it's only if the nuchal is thickened and nothing else is found, the yield, extra yield, incremental yield is about 1%. However, if you see other ultrasound findings, in particular fluid in the different body cavities, or you find other ultrasound abnormalities, the yield goes up tremendously, up to 3% in this paper and up to 14% in a paper by Scott and colleagues. So I think you've really got to look at other ultrasound abnormalities. And the next two slides will show you what I mean by that. If you've got a nuchal thickness that is more than 5 millimeters, that's one criteria for adding a rhizopathy panel testing. And of course, if you've got hydrops and you've got multiseptated cystic hygroma, so it's not just a nuchal thickness, it's hydropic features. And some of these fetuses have pleural effusions and ascites and subcutaneous edema right down to the lower torso. Then these fetuses will benefit from a Noonan's panel as well on top of your CMA. And what I sometimes do is I do a CMA and a PCR. If the PCR comes back normal and the CMA comes back normal, and I start off with a very thick nuchal of 5 millimeters or more, I would get the same lab to do a Noonan's panel on the villi that is still left, and they should be able to give me a result. And I don't order it if I've got a CMA that is abnormal. Of course, I would not proceed with a Noonan's panel, but I think that's one of the ways we try and save the patient some money and not over investigate. So we depend on what the results come back. And then if we may add a Noonan's panel or a rhizopathy panel on top of that. Of course, then the question arises finally, should we be offering a whole exome sequencing? And again, just for the benefit of our colleagues, whole exome sequencing is something that we have to start discussing about. I would bring you back to this very important paper again, and I'm referencing it for the second time. Bardi and colleagues looking at the single gene disorders, which is essentially how the whole exome sequencing will help. Yeah, just to make sure that we're all on the same page. Your PCR invasive test will tell you about your 21-18-13. If you did a chromosome culture, it will tell you about the other chromosome abnormalities. If you want to know about microscopic deletions or microduplications, you got to do a CMA. And if you suspect single gene disorders like Noonan syndrome or the rhizopathies, you've got to do a whole exome sequencing or a whole genomic sequencing. And therefore, it gets very complicated when you look into this particular group here. And that's where genetic counselors, geneticists have got to be involved before you order whole exome sequencing. And I would just like to point out that the incremental yield is actually about 4% for CMA and also for single gene disorders. And I'll show you some papers to substantiate that. So prior to up to December last year, when giving a lecture on this particular topic, we would quote these papers, very, very important papers using thickened nuchal skin folds. And you can see that the diagnostic yield varies from about 1% to 8%. And most would quote a incremental yield of about 4% in fetuses with a normal CMA and a thickened nuchal. Recently, with a very good paper from Pauter and colleagues from Spain, which reviewed and presented in a meta-analysis the incremental yield of next generation sequencing or whole exome sequencing in fetuses with an increased nuchal thickness. You can see that a lot of papers were used in analysis, 11 papers in total, using cutoffs usually hovering around 3.5 or more. Some would use a greater cutoff of 4, some would use 99th centile, but the vast majority 3.5 mm or more. And you can see from this particular paper that there was an pooled incremental yield of 4%. So I think that's another number to take home. To remember that there is an increased incremental yield of about 4% in this particular cohort of cases. Now, having said that, the decision whether to offer whole exome sequencing is a very fraught decision. A lot of the time, we actually have to get our genetic counselors involved to talk to the patient, and there are a lot of contentious issues in this. First of all, we are really only looking at WES or whole exome sequencing in these particular cohort of patients who have already had a first trimester screen, thickened nuchal, they've already had the invasive test, the PCR and the chromosome microarrays come back normal. You need to send them to a fetal medicine specialist. You need to get a 16 weeks cardiac scan. You need to refer them to the pediatric geneticist for pre and post-test counseling, because there are many, many issues that have to be sorted out even before the patient even begins to have the procedure to do the whole exome sequencing. What genes are we looking at? What are the potential problems with the interpretation of the variants? And normally we do look at the phenotypic abnormalities to guide us in our interpretation of the variants. and compare it to the literature. There is the issue of competing timeline, because a lot of the time these patients are beyond 16 weeks. They're approaching 19 weeks. They're getting their fetal anatomy scan at 19 weeks. We're awaiting further phenotypic abnormalities at 19 weeks to guide our genetic testing. And of course, the anguish of the patient having to wait all this time whilst waiting for the results. So it's a balance between getting the results, but waiting for phenotypic abnormalities to be clearly visualized in order to do the test in the first place. Not to mention the fact that genetic testing is very expensive. And that really, of course, here I'm just quoting some of the costs in Singapore, and these are just laboratory costs, not even including the PCR. It doesn't even include the chromosome culture if that's been ordered prior to this. Doesn't involve the fees that the hospital will levy. And I think, you know, the numbers are pretty mind-boggling. Looking at a CMA, which costs about $1,800 to $2,000. If you want to add on a Noonan's or Rhizopathy panel on top of that, it's about $1,600. And sometimes we find so many abnormalities, and we actually order the full package. We actually get the patient to have a CMA and a whole exome sequencing, and that, you know, alone is about $5,200 upwards. So, you know, it's sort of in completely different mind-boggling range of costs if the patient were to have to pay for the entire cost of the procedure fees herself. So it does raise important issues, and I think these issues have to be resolved before you can do a proper whole exome sequencing for these particular patients. So I think to wrap it all up, if you feel a bit confused after this talk, well, I think in a way it's good because it's been provocative. It's made you think out of your box, and it's made you think of some of the chromosome abnormalities that we are likely to face and which we expected to counsel our patients for as we move into in our counseling of our obstetric patients. And one of the excellent papers really that summarize what we should tell our prospective parents is this paper published by the colleagues from Melbourne. It's a paper by Joanne Kelly, but also with Simon Ma and Lisa Hui. A very, very good paper that breaks down the implications of an increased nuclear translucency into some of the areas that I've just discussed. And I would maybe finish with this particular slide here, a bit like a diagnostic pathway that I've advocated in this particular paper. I think the other thing, of course, is all these tests looking at the negative side, but I think it's also important to highlight to the patient that we are actually trying to eliminate disorders and to give them reassurance where possible. Let's go through this sequentially. We get a nuchal scan that is increased risk, even though they've had a normal NIPT. What do we offer them? We offer them a first trimester anatomy scan by a fetal medicine specialist. We may have to offer them a CVS or amniocentesis, and then you need to think, should I offer more than just CMA? Should I be offering them a Rhizopathy panel? Should I be offering them a whole exome sequencing? Am I waiting for abnormalities to develop before I have the confidence to do that? And then get to 20-week scan, and then you end up with having usually by 20 weeks, sometimes later, you may have all the information you need whether to consider exome sequencing. I think we finish on a positive note. It is also important to note that if your patient has had a normal CMA, had a normal a scan at 16 weeks and a totally normal scan at 20 weeks as well, we can actually reassure the patient of a 98% normal outcome. And I think that's important to put it in that perspective as well, because there are many patients who still fulfill these category and they get to 20 weeks and we've done all the scans, all the tests, and we should be able to reassure them also and tell them that, look, it's a 98% chance of a normal outcome, so that they can actually enjoy the rest of the pregnancy, having been put through the mill by us in the first 20 weeks of their pregnancy. The talk has gone over time. I apologize for that, but I'm sorry, I had a lot of ground to cover, and we look forward to the next talk by Professor John Hyatt in this series. Thank you very much, and we'll look forward to questions after the end of the 3 talks tonight. Thank you.
Thank you very much, Dr. T.C. Chang. We will now move on to the third lecture for this webinar. And for this, we will welcome back Professor John Hyatt, who will give the lecture on screening for premature labor. When should we screen and what screening modalities should we employ? So, Professor Hyatt, please.
Hello again. So this is my second talk, and this is about screening for preterm birth. And really it's focusing on how we can do this and when we should do this. So again, let's just recognise that preterm birth is a significant health issue for us. This is a slide that I took from a Facebook page for the March of Dimes in celebration of World Prematurity Day last year. And it talks about the 15 million babies across the world that are born preterm each year. And it talks about the potential consequences of prematurity. Now, in Australia and New Zealand, we know that prematurity is actually the most significant cause of perinatal death. So you can see here, highlighted in red, that in Australia, preterm birth accounts for about 16% of all perinatal deaths. Interestingly, in New Zealand, they tease the data out slightly different. So you can actually just focus on neonatal deaths, and you can see that about 32% of those are related to prematurity. That's consistent with data from around the world. So you can see here on the left-hand side, the black bars represent deaths related to prematurity, and then the greyer bars represent deaths for other causes in infancy. And so you can see that the early deaths particularly are those that are related to prematurity. On the right-hand side, this just looks at deaths before the age of 5. And again, you can see that about 40% of those worldwide are actually related to prematurity. And fundamentally, you're lucky if you live in a country that has invested in neonatal facilities, because these are very expensive and they require a lot of specialist medical care. We know that the implications of prematurity are more profound in terms of it's not just about surviving the first few weeks or years of life. It's also about long-term neurological outcomes. So, for example, the data on the left-hand side show that if you're born before 28 weeks, you have about a 10% risk of cerebral palsy. The data on the right-hand side also show the expense of preterm care. And you can see in the United States, and this is data I think from 2007, they spent $26 billion just on managing preterm infants. I actually use the financial aspect of this because I think when I'm having a conversation with someone about public health investment, being able to demonstrate how much money we spend at the moment on prematurity potentially gives me a window of opportunity for some investment in screening and prevention of this problem. So this is where I work at the moment in southwest Sydney, and we have about 14,000 births a year. And our preterm delivery rate runs between about 7 and 9%. You can see a proportion of those, almost 1%, are born before 28 weeks. There's then about another 0.5% born between 28 and 31 weeks. And they are by far more expensive than those babies born after 32 weeks. But if you do the maths, you can basically demonstrate that we spend about $65 million a year on prematurity. And I keep on telling the chief executive, I only want $2 million. You can keep the rest. So if we just look at preterm birth, we can really divide patients with singleton pregnancies into 3 groups. It's either an iatrogenic decision to deliver them, very often for preeclampsia or for fetal growth restriction, or they have spontaneous onset preterm birth, or they develop preterm pre-labour rupture of membranes, which often then leads to preterm delivery. So let's just focus for a moment on avoiding iatrogenic delivery. We've talked already about prediction of preeclampsia. I'll come to that in a moment. What I wanted to show you with this graph is you can see that we actually tend to make decisions in the green line about delivering women on the basis of them reaching various gestational points. So you can see there's a little hump at 28 weeks, there's another at 30 weeks, there's another around 34 weeks. So when you're making an iatrogenic decision to deliver someone, just consider whether you really need to deliver them today or whether you might be able to manage another week. If I just show you the impact of first trimester screening on preterm birth, this describes rates of preterm birth across Australia, 6.9%, in the late preterm group, and you can see 0.8% in that early preterm group, so total of 8.5%. New South Wales is very similar. RPA, a tertiary centre where I was recently working, slightly higher rate because of the referrals that we get. But then you look at the impact of the first trimester screening on a local population, and already we're beginning to see a significant reduction in preterm birth rates, and that's just with the implementation of preterm preeclampsia screening. You can expand that to screen for fetal growth restriction. We know that aspirin is the same treatment, and we can actually predict IUGR in some models. This is actually a Spanish model, very similar to the preeclampsia. You can see that they predicted about 90% with a 10% false positive rate. So this is an ongoing project for us to expand our preeclampsia screening to include fetal growth restriction. We've also got an ongoing project to predict preterm pre-labour rupture of membranes. So if you look at the etiology of this condition, there's a number of underlying causes, but there's probably a common pathway of inflammation of the membranes causing weaknesses in the membranes. And you can see this common pathway involves arachidonic acid, and there's the potential to block that pathway, again, with a drug like aspirin. So we actually did a study where we looked at the impact of aspirin given to women because of preeclampsia on the rates of PPROM. This slide is a little bit difficult to navigate, so I've color-coded it. So if we start with the blue bars, just the process of screening women for preeclampsia actually identifies women who are more likely to get PROM. So you are a 3% prevalence if you're in the high-risk group, and only a 1% prevalence if you're in the low-risk group. In the red bars, if we then look at what happened in an interventional cohort, so here the high-risk women are given aspirin, then you seem to get some reduction in prevalence of PROM in that group. But also notice that in the low-risk group who had no treatment, the PROM rate was actually slightly higher than it was in the first data set in blue that I showed you. But if I compare the two high-risk cohorts, so this is in grey at the bottom, you can see that you do seem to get a modest reduction in rates of PROM by giving women aspirin who were high risk for preeclampsia. So we've taken this a step further. We started to investigate whether we can generate our own algorithm for PROM in the first trimester of pregnancy. This is the first step in that work. You can see that the ROC curve on the right-hand side shows we're not quite there yet. We really need to try and improve this tool. One of the things we're doing at the moment is looking at whether first trimester assessment of cervical length helps with this model. But the rationale for doing this is really about the fact that if we could just delay PROM by a few weeks, we could potentially make significant differences to outcomes of pregnancies. You can see if you have PROM before 20 weeks, you're much more likely to lose your baby than if you have PROM after that period of time. So let's move on to assessment with cervical length. And this is now looking at the context of trying to predict spontaneous onset of labour. It could be in a variety of different groups of women. So on this timeline, you can see something we know impacts your risk of preterm birth is that you've had bleeding in early pregnancy. Obviously, you might actually attend with bleeding or pain in pregnancy, so that would be what I would describe as a symptomatic group. We've then got the potential to screen women at 12 weeks, at 16 weeks, at 20 weeks, and thereafter. Traditionally, for most asymptomatic low-risk women who we'll focus on, we start around that 20-week mark. But if you've got someone who is asymptomatic but high risk because they had previous preterm birth, you can certainly start much earlier. There's not just cervical length available to us with ultrasound. We can also use fetal fibronectin for this assessment. And we should think about pursuing this beyond the 20-week point, because if we can demonstrate someone has a risk of preterm birth even later in the pregnancy, it might help us determine when we should give them, say, steroid cover to improve outcomes. So this is one of the first studies looking at using cervical length to predict preterm birth in women who were asymptomatic. And in this study, actually, most women were around 24 weeks gestation. The graph on the left shows that in the black bars, the shorter your cervix is, the more likely it is you will go into preterm labour. The normogram is just a demonstration of the range of cervical length that you see in a population. On the right-hand side, the survival curves basically show you that if your cervix is less than 25 millimetres, you're much more likely to deliver preterm. There's now several other data sets that support this early work. So how should you assess the cervix? This is an example of a transabdominal scan. And the problem with a transabdominal scan is the distance between the probe and the cervix, which makes accurate assessment difficult. So you can see here, in order to see the cervix clearly, we've got a nice full bladder. But the problem with a full bladder is it essentially elongates the cervix, so that negates the impact of your measurements. If you have a relatively empty bladder and you have a cephalic presenting fetus, then you can see the problem is that you get lots of dropout from your ultrasound and you can't really see the cervix properly at all. So we did a study comparing transabdominal and transvaginal assessment of the cervix. We found that in order to see the cervix with a transabdominal approach, you really did need to have a full bladder. And we found that if you did have a full bladder, you made your cervix about 20% longer. And when we compared a transabdominal scan to a transvaginal gold standard, we would have only picked up about 10% of those women that had a cervix less than 25 millimetres if we'd started with a transabdominal approach. So this is something that is recommended. It's certainly in a lot of American literature, is they suggest doing a TA scan first. In our mind, this will mean that you will miss a lot of cases of a short cervix. So if I show you a transvaginal picture of cervical length, I think immediately you can see there's much better definition here. And this allows us to measure the cervix much easier. You can also see here that we now have a funnel on the internal os, and in fact we do have some cervical shortening. But you can imagine that if you were doing a speculum examination and looking at the cervix from the external os, it would in fact look completely normal. And that's the value of the transvaginal scan, both in advantage over a transabdominal scan, but also over a traditional clinical speculum examination. So, like everything that we've done a lot of research at the Fetal Medicine Foundation, we have a standardized method of assessing the cervix. It's important that we measure things in a standardized way. We have good normograms. This is produced by Laurent Salomon and his group in Paris. We know that about 2% of women will have a cervix less than 25 millimeters at 20 weeks. And we know from this data, again from the Nicolaides group, that the shorter your cervix is, the higher your risk of preterm delivery. And in this data set, you can see that that likelihood ratio starts to increase above 1 once your cervix is less than about 25 millimeters in length. Just as I showed you for the preeclampsia, again, you can take individual sonographers and you can assess how they're going from a screening perspective. So you can see here there's a blue line going along the x-axis. That's the sonographer that's behaving very, very well. But then you can see also we've got a sonographer that's outside of those red bars where they're tending to undermeasure cervical length. So you can identify that and you can then go and do some more education to try and correct that. This is another example of a short cervix. So here you can see the cervix is only about 6 millimeters in closed length. Again, it demonstrates the fact that effacement is happening from the internal os moving outwards. We know we have an effective treatment. This was the randomized controlled trial that we did in London that showed that if women were given progesterone because of a short cervix, you had a 44% reduction in rates of preterm birth. This is supported by the work of Romero's group, and you can see here again significant reductions in rates of preterm birth. Romero's also produced a meta-analysis for the randomized controlled trials that have done this that shows significant value, and more recently this has been combined in an individual patient meta-analysis known as EPIC, published last year. First, it showed a reduction in rates of preterm birth for women who had a short cervix given progesterone. Second, this chart just demonstrates it shows improved neonatal outcomes. But you do need to be aware that in twins, the data aren't so good, and it's not particularly supportive of the use of progesterone for a short cervix in a twin population. So where does this take us? Well, as well as having that meta-analysis that shows the value of progesterone, this is some data that wasn't actually published from the De Fonseca trial that shows that progesterone seems to work best for women that have a relatively long short cervix. And if you have a short cervix, it's not such a good performer. And so that brings about the issue of whether you should also use cyclage. And certainly there are circumstances where the cervix is below about 5 or 10 millimeters, where we would typically choose to put a cyclage in instead. We've also been investigating using cervical elastography, and this can be done in two ways. One is to measure strain, the other is to basically measure the stress across tissues. And we've now produced normative data for what softness of the cervix should be across the gestational ages. What we need to do now is actually identify whether this helps us as an additional tool above and beyond cervical length to predict risk of preterm delivery. So where should we be going next? Well, we know that preterm birth can be predicted using a number of different factors. If I just show you those graphically, you can see that obstetric history is important, but if I make a comparison between those traditional risk factors and cervical length, you can see how much more significant cervical length is. There is a risk calculator on the Fetal Medicine Foundation website that allows you to calculate individualized risks for preterm delivery. This isn't the only software available. This is actually an app you can use as a patient that describes your risk. We can use this in combination with fetal fibronectin, and you can see this might be of more relevance to people who are already symptomatic. And this Dutch study basically showed that if you had a cervix that was less than 15 millimeters and you used fetal fibronectin in addition, that it was a useful way of predicting preterm birth less than 7 days. If you just tease the data out a little bit more, in fact, the higher your fetal fibronectin level is, also the higher your risk is. This is reflected in something called the QUIP Act. I've just put together a few slides just to demonstrate how this works. This is from St. Thomas's Hospital, but you can download it onto your phone. You can put in measures both asymptomatic and symptomatic patients. You can then calculate risks of preterm birth at various gestational cutoffs, but also within the next week. Helps you work out whether you need to admit women, whether they need steroids. And you can just see how you use different risk factors in terms of these calculations. Just to finish, you can measure cervical length in the first trimester, but the normal range is actually slightly shorter than the normal range at a later gestational time point. You can put that together with other factors, such as the biochemical marker AFP, and with maternal history, to produce a predictive algorithm for preterm birth. But there is some argument about the value of cervical length in the first trimester, and some groups have not been able to reproduce this. We do think, though, that cervical length will be useful in the prediction of preterm, pre-labour rupture of membranes. So just to finish, this is an example of other markers that we might be able to use. So we might be able to look at the vaginal microbiome to predict spontaneous preterm birth. And if we look at some of the epigenetic and genetic markers that we have in our bloodstream, so this is akin to looking at cell-free DNA, then you can basically see that if we look at maternal microRNAs, there is a specific signal that's associated with preterm birth. So it might not just be ultrasound that we rely on in the first trimester, but we might put it together with a combination of other tools as we move forwards. Finally, if you want to know more about using cervical length for preterm birth screening, I would advocate this website from Western Australia called The Whole 9 Months. Thank you.
Thank you, Professor Hyatt. So we've now come to the question and answer session. And so we've got all our panelists, Dr. Chang, Professor Hyatt. Thank you for joining this webinar. I think we're still waiting for some questions to come in. Yeah. So if you have any questions, could you please type them into the chat box? Yeah. So while we are still waiting, maybe I will start with a question for Professor Hyatt. For the preeclampsia prevention screening, is there an accreditation process for performing the uterine artery Doppler measurements, like for nuptial translucency?
So there are accreditation processes, and I would certainly suggest that people enroll in some type of audit program. If you're a member of the Fetal Medicine Foundation family and do your first trimester screening certification with them, then you can use the same program to extend that. There's some educational material on uterine artery Doppler measurement and on use of the algorithm. And then there's an audit process as well with that. And similarly in Australia, actually, we run a national program of accreditation for first trimester scans. And we can use the same process for uterine artery Doppler here in Australia. So I think it's just important to recognise that risks that we give to patients are only as good as the data that we've used to produce those risks. And from my perspective, uterine artery Doppler is something that has to be done in a standardised way if it's going to be of value in screening.
Okay, thank you, Professor Hyatt. Yeah, so please type in your questions in the chat box if you have any. So we're still waiting for some more questions. So maybe I have a question for Dr. Chang at the moment. Medical legally, Dr. Chang, will there be an issue if we just do NIPT as a sole method of screening offered to patients in the first trimester?
Yes, I think that's a very good question. I think I would be certainly a little bit worried if that was a sort of a universal practice, because that would then, it really doesn't lend itself to easy medical legal defense. You can imagine the scenario where the patient has a NIPT, has a cursory scan to measure the crown rump length, and then they then turn up at 20 weeks to have the anatomy scan. I just worry about the information that could have been gleaned from a very good first trimester scan and all the missing data points that could have been, we could have sorted out problems earlier. And of course, you missed the opportunity to screen for not just organ abnormalities in the first trimester, but also other chromosome abnormalities, chromosome microdeletions, and others. So yes, I would be a little bit worried, and I certainly wouldn't encourage that practice amongst our colleagues. So either do your NIPT at 10 weeks if you must, and then do your first trimester scan after that, or do your first trimester scan as a sort of triage, and then do your NIPT, or if you want to do combined first trimester screening, that's fine too, but not NIPT alone.
How about Professor Hyatt? Do you have any opinions or comments on this? Or just doing NIPT without any ultrasound scan?
I think NIPT is a test that works well if you have a lot of money. And I think fundamentally any screening test has to be applied to a population to be effective. And so if only a small proportion of people can afford the screening tool that you're using, then you're going to be in a position where you actually detect fewer cases of a condition than you would have done if you'd applied, if you like, a slightly lower efficacious screening test, but you'd managed to apply it properly across the whole population. So, I think our experience in Australia is that a lot of women are choosing to pay for their NIPT tests, but the government has decided that they don't see any health economic value in that. So it does mean that it's a test that's available to patients on the basis of their own ability to pay or to fund it. And I have concerns about that in the context of a health service, if you like, for a population of patients.
Okay, thank you, Professor Hyatt. There's another question, I think, for Dr. Chang. So this is from Woon Ping Hu. For patients who have had IVF PGS, do you still advise them to undergo NIPT? Dr. Chang, do you think you can?
Yes, I think the short answer is I would still offer NIPT in that specific cohort. I think the question is referring to IVF patients who've had PGD done and of course now seeing us at, say, 11 to 12 weeks. I would still do what I would do for any other patient who hasn't been screened with a PGS. I would still offer them NIPT, and I'll still offer them a first trimester scan. Because you can't exclude all abnormalities at the PGD, and there's also the evolving the change in chromosomes. So as the gestational age matures, so you really want to offer that still. So it doesn't preclude you from omitting that. Let's put it that way. I will be very interested to hear what Professor Hyatt thinks of that too.
Professor Hyatt, same thing.
Look, I think I agree with that comment. I think we have to be quite rational about the way that we use NIPT. I think that we've become very excited because it's a new technology, and obviously it has a very high efficacy when you apply it for a very distinct and small range of chromosomal abnormalities. And, the reality is that if you're checking a fetus for anomalies of chromosomes 21, 18, 13, X and Y, that only represents 50% of all chromosomal abnormalities. And I think that Dr. Chang mentioned this in his lecture. When I talk to my patients, what they want is a test for chromosomal abnormality, not for a small list of chromosomal problems that are a subset of all chromosomal abnormalities. So I think it's really important that you make sure that your patients know that, yes, I have checked you for this series of conditions, 5 conditions, but if there's something else going on, we've not done that with this test.
Thank you, Professor Hyatt. One more question for you, Professor Hyatt. It's a question about using translabial or transperineal scan instead of transvaginal scan for cervical length measurements. Do you think this is useful or?
Yeah, it's actually quite an Australian technique. It's quite common for people to do translabial scans here. It has a number of advantages. It means that you're not actually putting a probe inside the vagina, and for some women that's significant. It also means that you can use a transabdominal probe wrapped in a glove or something like this. So if you don't have a TV probe on the system, that works well. I think it has a number of disadvantages as well. Whilst a translabial approach avoids actually putting something inside the vagina, it's still a very intimate examination. And for some women, they would actually be more uncomfortable with, that pressure of the probe on the labia than they might be with a transvaginal approach. I think also I find that sometimes the image, because of the pubic bone, sometimes it's difficult to see the whole length of the cervix. So I find actually it works very well in circumstances where the cervix is very short or indeed beginning to dilate. But often it's harder to actually quantify the length of the cervix properly in women that have a longer cervix.
Okay, so it's you do not use this for your validation studies that you have done so far, the translabial or transperineal scan?
So personally, I made a decision that I found it probably more uncomfortable for patients in terms of just their own comfort about being examined than actually just getting on and doing a transvaginal scan. So the images are certainly not of the same quality. So I guess that the main reason that I've stuck to doing TV scans is because I think that the image is best quality that way. I think if you choose to do a TA scan and then have a cutoff where you go to a TV scan at for a small percentage of the population, I actually don't think that's a particularly good process. The data that I've had in 2 different populations says that actually that has very low sensitivity and specificity. And that data is conflicting to what comes out of some other centres. But I think, preterm birth is a huge issue, and fundamentally it will impact patients for the rest of their lives. And I think that if you put that into its proper context, then actually making sure that we spend a bit of time doing the screening test properly is worthwhile.
Thank you, Professor Hyatt. Yeah, so please type in your chat if you have any further questions. Maybe for now, just one more question for Professor Hyatt. Regarding the elastography scan of the cervix, so far at what gestation has this been done? Is that in the first trimester or in mid-trimester? At what gestation has this been done for your patients?
Yeah. So in fact, I can put a plug in for Canon here, because Canon have a method of doing elastography that is amenable to calibration, whereas a lot of the other techniques are based on the pressure that you put on with the probe, and it's actually very difficult to calibrate that between patients. So one of the reasons that we did our elastography work on a Canon system was because we felt that actually we could be making a measurement that was comparable between different patients. We've made a series of measurements in a whole host of low-risk patients now, 11 to 13 weeks, around the 20-week mark, and then in the third trimester of pregnancy. And certainly you can see differences in cervical consistency. One of the problems is that the normal range has quite a large standard deviation. And when we calculate risks with measurements in ultrasound, say for nuchal translucency, what we're relying on is basically looking at the difference between a normal population and an abnormal population. And if you have big standard deviations to measurement, that actually makes that a bit harder. It also makes repeated measurements harder. So I'm not yet convinced that elastography is going to really add significant value to what we're doing with cervical length alone. I think if it does add value, it will be in its negative predictive value. You know, if you can say that someone who's got a short cervix where you're thinking about an intervention, actually it's short, but it's hard. And that means that you don't think it's effacing and therefore they don't need an intervention, then that would be a significant benefit. Yeah.
Okay, thank you very much. So I think that's all the questions that we will be taking at the moment. And we thank you, Professor Hyatt and Dr. Chang, for your lectures and for your answers to our questions. So we would like to end the webinar now. Yeah. So from Canon, do remember to send us your feedback, and we look forward to seeing you again